Hello, everybody. Thank you for attending this presentation. Thank you very much to OHBM for having us. My name is Aaron Lowe, and I'm a third-year PhD student in Dr. Lozano's neuroimaging lab. And today I'll be presenting a presentation entitled Clinical Correlates of fMRI Response to Deep Brain Stimulation. So just to give a bit of background, what is deep brain stimulation? So DBS is an established therapy for various movement disorders, most commonly Parkinson's disease, but also dystonia and essential tremor. And DBS has also shown promising application in a range of psychiatric, cognitive, seizure, and pain disorders as well. And so in DBS, electrodes are permanently implanted to stimulate specific brain regions that are associated with the dysfunctional neurocircuits implicated in some of the aforementioned diseases. So in PD, commonly DBS targets include the subthalamic nucleus or the internal globus pallidus, which are key motor hubs. So once the electrodes have been implanted in DBS, stimulation must really be fine-tuned for each patient so that they can achieve their maximal therapeutic benefit. And this involves titrating stimulation parameters, including the active contact, as well as frequency, voltage, and pulse width. So why would we bother with combining fMRI and DBS? It's got some safety challenges and other logistical challenges. And so what can we gain by combining these two techniques? Well, in the first instance, and very relevant to this convention, is human brain mapping. And so with DBS, this is a tool that allows us to directly engage with neurocircuitry and probe neural circuits. With fMRI, we have a way of observing these effects and whole wide brain responses in vivo. So the two together are a really powerful tool for charting the human brain. And then sort of on the more therapeutically minded side, fMRI and DBS could also be used to identify imaging-based biomarkers for DBS. So we could identify patterns of fMRI response that are associated with DBS stimulating the right network, or it could be used as the endpoint for selecting the clinically optimal stimulation parameters that I touched on earlier, that are patient-specific. And so this isn't really our group that just thinks this. If you look at the last couple of decades, you can see that there's really been a proliferation of fMRI DBS studies. And while the field is relatively small still, as a whole, you can see that in the last 5 years, certainly there's been a real uptick in the amount of DBS fMRI studies. And not just that, an increasing number of studies at 3 Tesla as well. And sort of we feel this has come with a growing recognition of DBS fMRI safety and also sort of the utility of combining these two tools. And if we sort of break down the literature to date, what we can find is that most studies have been looking at fMRI responses to deep brain stimulation in Parkinson's disease patients. And most of these studies have looked at the effects of stimulating the subthalamic nucleus, which is the most common target for Parkinson's disease. We also look at the type of experimental designs that have been employed. We find that most often groups tend to use a cycling stimulation fMRI design, which is to say that they employ a traditional fMRI block design, wherein the task in this case is stimulation. So stimulation is turned on and off periodically during the fMRI acquisition to derive contrast maps showing the effect of stimulation across the whole brain. So what does the literature say about fMRI response to subthalamic nucleus DBS in Parkinson's disease? So we identified 10 studies in a previous review that have looked at this specific question. What we found is these studies consistently implicate areas of the motor circuitry, including the sensorimotor cortex, thalamus, basal ganglia, and cerebellum. But what is interesting to note is that while the majority of studies show that subthalamic nucleus DBS is associated with fMRI activation or bold activation in these areas, some studies show deactivation. And this is a question that the literature needs to resolve in the future. Then again, on that more clinically focused side, a previous study by our own group looked to see in patients who had already had DBS and who were already on their most clinically optimal stimulation settings, there was a characteristic pattern of fMRI response associated with them being on the settings that worked best for them clinically. What we found was there was a characteristic pattern of fMRI activation regardless of what each individual patient stimulation settings were. And that involved the sensorimotor cortex and thalamus and cerebellum. What you can see from this figure is that when stimulation is moved away from what we knew to be therapeutically optimal, that pattern diminishes. However, looking through the literature and even in our experience, the relationship between fMRI responses and long-term clinical outcome hasn't really been thoroughly examined. So that was the goal of this present study. And so what we did is we performed fMRI in 40 patients who had DBS targeting the subthalamic nucleus. And these are all patients who had already had their stimulation settings optimized. So people who were typically about 2 years after surgery, and who we knew what their best stimulation settings were. What we aimed to do was correlate their individual fMRI response with their clinical improvement from DBS. And we wanted to do this in terms of their overall mode improvement, as well as their mode improvement in each of the subdomains or individual symptoms of Parkinson's disease, including tremor, rigidity, bradykinesia, and gait. So in terms of the individual fMRI acquisitions, each patient underwent a 6-minute long fMRI acquisition, and scans were performed on the stimulation settings that resulted in their greatest clinical benefit. And during each fMRI acquisition, we employed this fMRI block design that I touched on earlier, in which stimulation was automatically turned on and off every 30 seconds to derive an fMRI response map or a contrast map for each individual patient. And just to really differentiate between unilateral or contralateral effects, we only performed stimulation with one electrode turned on, which was the left electrode. And so to correlate fMRI response and clinical outcomes, we looked at 16 a priori regions of interest. And these regions of interest were derived from the fMRI the DBS functional neuroimaging literature. So these are areas that had commonly been implicated in the prior literature and previous studies from our group. And these areas included motor regions as well as a variety of non-motor regions. And so we had, across the 40 patients, we had 40 individual fMRI response maps. We correlated the mean fMRI response in each of these regions of interest with each patient's clinical improvement following DBS. So this was their percentage change from baseline in overall motor improvement, as well as motor subscores for each of the cardinal symptoms of PD. So tremor again, rigidity, bradykinesia, and axial symptoms. And what we found after doing all that was really there was only two combinations where there was a significant correlation. And so we found a significant correlation between axial symptom improvement and bold signal change in the right anterior cerebellum, and axial symptom improvement and bold signal change in the left sensorimotor cortex. And all other correlations were not significant. So that was a little bit surprising. I think we thought we found more areas that were significantly associated. And so what we did next was to see if there were areas outside of those a priori regions of interest. We did a whole brain analysis. A whole brain post hoc analysis. And to do that, we compared fMRI responses in DBS responders and non-responders. So responders were those people in the top 25% of clinical improvement for overall motor improvement and for each of the subdomains of motor improvement. And non-responders were people in the bottom 25% of clinical improvement. And we did a t-test between fMRI response maps in each of those two groups. And we did that for each of the individual symptoms of PD. What we found was that areas outside of our a priori regions were implicated, including frontal regions and temporal lobe and insula and anterior cingulate. And what we also found was interesting is that these areas that were different between responder and non-responder groups were also distinct when comparing the individual symptoms of interest. And so our conclusion from all this was that, firstly, we do have preliminary evidence of an association between DBS-evoked fMRI response and long-term clinical improvement following DBS. So this is therapeutic implications in prognostication, but also in selecting the clinically optimal stimulation parameters for each patient. What we also found from a more mechanistic point of view is that brain regions associated with clinical improvement included areas outside of what we would traditionally consider the cortico-basal ganglia-thalamo-cortical loop. And not only that, but these regions were different depending on the specific PD symptom that we examined, suggesting that there may be symptom-specific networks of DBS efficacy. And this also has implications for personalized medicine and personalized titration of stimulation parameters, depending on a patient's specific, depending on their specific symptom profile. So thank you very much for listening. Of course, this work couldn't have been performed with the many members of our lab and our many collaborators, and also the generous donations of the Michael J. Fox Foundation who have helped to fund this research.